Thank you, Liz. It is a great panel, and it's a great opportunity to discuss this topic, which is it's quite timely. It's toning it down and maybe taking it a couple of notches down after the tour de force that you just heard from this morning's session. But I thought, it would be nice to have this as an interactive discussion because it's a topic that's being discussed in cardiology circles at great depth, and it's actually been quite entertaining to watch the debate in the last 4 or 5 years about something that's as seemingly intuitive as the management of stable ischemic heart disease and coronary artery disease. We're in an era of what everyone is now calling the evidence-based medicine era, or as I call it sometimes, the evidence-based medicine mirage, with leading on to what we're now calling the less is more crusaders or medical reversals. In other words, procedures that have been taken for granted, whether it be in cardiology or other medical specialties, such as arthroscopies or surgery for back pain or whatever that might be, are now being re-examined under the umbrella of evidence-based medicine and re-examining whether, in fact, we're doing the right thing for those patients. And probably stable ischemic heart disease is starting to fall into that category, but the debate is certainly not finished. It's a very engaging debate, and there is more depth to it than what might seem at the surface. And I want to bring out some of the issues within that concept of assessment or screening for stable ischemic heart disease even, assessment, and then subsequent management for ischemic heart disease. So we'll see how we go and see if we can cover some of these topics. Now, the basis of the discussion is going to be this. I'm just going to present one simple case. And this is a patient that I saw, it was about 2 weeks or 1 week after I came back from holidays in January. And it struck me in that this is the patient that we all mostly see there's lots of patients with life-threatening problems, but this type of patient is probably the more common patient that we see in our patients, and I'm sure you do as well. So the basis of the discussion today is going to be around this particular case, and we won't discuss it right now, but I just wanted to put that up so you can keep in mind, if you could just sort of copy and paste that in your brain and remember the details as we go through this discussion, and then we'll go through some of the concepts as we go along in the next hour. So the patient is a young, healthy 54-year-old with no prior medical history whatsoever. He's actually a medical professional. Obviously, we'll keep the details confidential, and very well engaged in the discussion and informed about all the various concepts that we're going to go through. He presented under this question of appropriate cardiovascular screening for his situation. He is asymptomatic, but the precipitant for the presentation was that his mother died just recently from a myocardial infarction, but at the age of 80, and that his father had a myocardial infarction at the age of 67. He's a non-smoker. He exercises at a high level, almost at athletic levels, and has no symptoms related to that. He's of thin stature. Body mass index is between 24 and 25. His blood pressure is normal, and that's his lipids. As you can see there, the LDL level is at 3.68, HDL 1.21, triglyceride level 1.5, and his fasting blood sugar level is normal, and the HbA1c, as you can see there. So that's the basis of what we're going to go through today. And I want to sort of try and get out of the cardiology fast lane in order to do this. Now, before we put this patient on the merry-go-round of medical procedures, we kind of need to take a step back a little bit and work out what we're actually aiming to achieve in the process of assessing and managing this patient. Because if you do get in the fast lane, he ends up on the medical round, which we may well do by the time we finish the presentation. But taking a step back and assessing what we're trying to achieve is probably going to be a bit more fruitful. And this reminds me of what's happened in the last, just to put it in perspective or give you some contextual information. This is actually the picture of the first ever balloon angioplasty that was done in 1977. 1977 doesn't seem all that long ago for us that are a bit older. In 1977, I was actually in Melbourne, having just emigrated from Cyprus, and I would have been in primary school going to high school. I think Jim Cameron, if he's still here, he might have been in medical school at that stage. Damien, I'm not sure if you were born, were you? Yeah, so I don't know if you remember the fanfare around the first balloon angioplasty. That was a big deal by this pioneer, Andreas Grunzig, treating a proximal LAD with balloon angioplasty, as you can see from the photos there. And this gets brought up time and time again. These were the real pioneers in procedural cardiology. So the 1980s, and then things exploded. And the era that followed that was the technical era. It wasn't really the subtleties of what we want to discuss this morning. It was the technical era of developing what we can do and how to manage fixed stenosis. So the 1980s was the balloon era with its various drawbacks, and then the 1990s, which I went through. That was the time when the first stents came out in 1994 and 1995, and I was a registrar. I was Gene's registrar at the Prince Charles Hospital. I specifically remember the day when the stents were brought into the cath lab, and then the explosion of the stent mania in the 1990s, and then the refinement of those stents to the drug-eluting stent era that we've had in the last 15 years. So the explosion of procedural aspects was between this period and the sort of early to mid 2000s. The first decade of the 2000s. Now, the last 5 years has changed a little bit. We've got to the point where there are not many technical challenges in angioplasty that can't be, it's gone from bypass surgery, really being the only way to revascularise people, to stents just about replacing everything in terms of revascularisation. So we know that there are things that we can do, that there are some amazing technical operators around in Brisbane and around the world, but the last 5 years the mindset has changed a little bit. It's now more about the subtleties of who really benefits from revascularisation, and that discussion is much more complicated and much more nuanced than the technical discussion that's been going on in the last 2 decades. So that on one side is what they call the less is more crusaders, who don't believe in revascularisation at all in stable ischemic heart disease, and on the other spectrum are the clinicians who've been doing this for a long time, and they can use their clinical judgment to work out certain subgroups that might benefit, and in the middle are the various trials that we can look at for all their strengths and weaknesses. Now, the key thing in stable ischemic heart disease is the pathophysiology behind it. And that's the concept that's absolutely critical in making the decision. So patients with ischemic heart disease or coronary disease have plaque in their coronary arteries, but that plaque is at a spectrum. So for example, this plaque here is what I would call a stable plaque. So this plaque is smooth, it doesn't have any degree of ulceration in it. It's causing narrowing in the vessel, but it's a smooth plaque. It's a stable condition, it's low risk, it's not related to unstable angina or myocardial infarction. The transition of this plaque to an unstable plaque, and this is the key point, that you always, and I always find this hard for patients to understand, and in fact some doctors find this concept hard to understand as well. The progression of this plaque to an unstable plaque has nothing to do with the degree of narrowing. So in other words, whether this is a 20% narrowing or 60% narrowing or 80% narrowing does not determine the risk of this plaque causing a heart attack. The presence of the plaque is the risk, not the narrowing. So when you put a stent in an artery, you push the plaque sideways, but you're not altering the risk of myocardial infarction. And why is that? Because most of the plaques that the patient has are not going to be treated with stents because they're all 20% plaques. So they still have the risk of rupture. So when we put a stent in a patient, the patient thinks we've saved their life, but in fact that's not the case. This is stable angina that I'm talking about, or stable ischemic heart disease. All we're doing is pushing the plaque sideways and improving blood flow. It has nothing to do with preventing heart attacks. Preventing heart attacks is all about preventing these sort of plaques from rupturing and causing a heart attack. All right, so that's the key message. So this is the unstable plaque. As you can see the difference. It's an ulcerated plaque. It's high risk because it can thrombose within a space of a few minutes and cause a heart attacks. Now the difficulty and the challenge is how to recognise whether a patient has those plaques. So I guess this is the first point, is there any way at a clinical level when a patient comes to see you that you can assess whether they've got this sort of plaque in their heart or not? Is there anyone willing to Evan? So how would that help? A stress echo, determine whether the patient has a...
muscle isn't contracting the way it should with exercise, or it's not moving at all, it would indicate that area is ischemic.
Yeah. Okay, I'm going to challenge you because I want this to be a challenging discussion. And the key thing is that's stress echo can't tell you. The stress echo can tell you... Actually, I'll put it to the panel. Malcolm, can you answer that question?
So, stress echo will identify flow-restrictive coronary artery disease. Okay? So if you read one of my reports that's normal, I say no evidence of flow-restrictive coronary artery disease. Right? And the implication there is that a normal stress echo doesn't say you don't have coronary artery disease. You may or may not have coronary artery disease, and if your risk profile is adverse, then you probably do. But the normal stress echo implies that you cannot provoke supply-demand imbalance within the myocardium, which would imply the absence of a flow-restrictive narrowing. So a stress echo won't identify the unstable plaque that might be going to rupture tomorrow or the day after. Anyone else want to say anything?
So stress echo, so we want to identify plaques. So I want to know from you if you have any ability in your practice to determine which plaque. So the patient wants to know if they're going to die from a heart attack. Do you have the ability to predict if that patient has an unstable plaque?
I can't think of any way of knowing that an individual plaque being unstable, but risk factors for plaques growing like lipids or inflammation, inflammatory markers, things like that.
Absolutely. So correct. Number one, risk factors. So there's a risk of plaque rupture. It's not identifying the plaque, but you're absolutely correct. So there are risk factors. Anything else? What would you want to know about their history to see if they've got an unstable plaque? Absolutely. So unstable angina, in other words, recent onset of symptoms would tell you that there's something going on. So risk factors, symptoms, anything else? Sorry? Yes, absolutely. In terms of the risk profile of that particular patient, yes, but not necessarily telling you at that point in time whether they have a plaque that's vulnerable.
Peter, can I just say about the symptoms that it's probably worth drawing a distinction between the symptoms that we commonly associate with stable angina and the symptoms that we associate with unstable angina. So stable angina would be textbook angina, chest pain, chest tightness, constriction, Bourdon-Bowe effort relieved by rest, which implies a supply-demand imbalance scenario associated with a plaque that is not changing. Whereas unstable symptoms can be more often than not, at rest, or they might be exertional, but they also may be non-exertional. They could be rest symptoms and sometimes stuttering symptoms, yet they still maintain a characteristic consistent with the locale or the descriptor of angina, but it doesn't specifically occur with exertion. Do you want to draw on that?
That's a great point that Malcolm is raising, and that subtlety has actually been raised in a lot of the randomised controlled trials on stable ischemic heart disease. What's one man's stable angina might be another man's unstable angina. And I would actually make the point, and this is controversial, that the first episode of chest pain in anybody, by definition, has to be unstable. So at what point do you label something as stable, and at what point do you label something as being unstable? And this is the subtlety that's not picked up in the randomised controlled trials. The randomised controlled trials label everyone as stable ischemic heart disease in that scenario, but by definition, at some point in the patient's journey, they would have been unstable before they became stable. What about the rest of the panel? Are there any other indicators of
Microvascular changes, so retinal changes.
Yeah. Look, I think we talk about this concept of plaque burden. So the more plaque burden there is, the easiest way to think of it is the more plaque there is, or the more number of plaques there are, the higher the risk of a heart attack. So if a person has one plaque, that person is going to be at lower risk than a person who has 30 plaques. And that's the sort of concept of plaque burden. And assessing peripheral vasculature and retinal arteries is probably, and carotid arteries, to some degree. I mean, patients often ask me, should I get my carotid arteries screened? And sure. And that's just a sort of indirect marker, I guess, of plaque burden. So what you're saying is probably true as well. If the ophthalmologist is telling us, look, there's a lot of vascular diseases in the eyes, that's probably another one of those markers of plaque burden. I guess I'm trying to work out if there is a way we can stratify a patient where we think they've got this sort of plaque in their heart rather than this thing, which is where you can sort of relax a little bit and look at some other aspects. I want to, yep. So inflammatory markers, are there any inflammatory markers that are useful in determining unstable plaque? What about CRP, D-dimer, does anyone believe in those? CRP has been discussed and it's good, but the problem with it is it's not specific. And so that's the whole concept of sort of inflammation. And then, so because we've got quite a bit of ground to cover, obviously the markers. So this is what we want to get at, right? So the category on the left are the low risk patients with stable or non-cardiac disease. The best marker that we have at present to determine an unstable plaque is troponin. Now, when I was a registrar, the only marker we had was the CK level. So the sensitivity of those tests, sorry, yeah.
I was wondering whether the calcium scan CT comes in.
Yeah, we'll get onto that. But before, that, I mean, the key thing that I want to separate is being able to distinguish stable plaque from unstable plaque. If there was a test you could do, a hypothetical test, we'll call it the Hadji-Petru-onitis test, to tell you that the patient has an unstable plaque, it doesn't matter whether it's 10% or 20% blocked, I'd go in and put a stent in it and fix it. The reason I don't do 20% blockages now is because I don't know which plaque is unstable. So the best tests that we've had are the CK level. The problem with CK, it's not very sensitive. So we have lots of patients with unstable angina and unstable plaque that have normal CKs. So then we had what these so-called high sensitive troponin assays, which are much better. But even heart-sensitive, Alex, are the heart-sensitive troponin assays perfect at diagnosing unstable angina?
No, Peter, because there's obviously a small percentage of patients who will have troponin detectable. There's also other factors that might interfere with your troponin assay, such as renal failure.
So why is it important to separate those two groups? So here's the graph here. Can you talk around that, Alex? Can you see that from there? Why is it important to separate patients from troponin positive to troponin negative patients?
The evidence tells you that over a period of follow-up, the people that are troponin positive will have a higher risk of acute coronary events. And so it's important that those patients are identified for aggressive treatment. Is that what you're...
Yeah.
Going further along the line, obviously your CK level is then at a stage where you're then talking about possible myocardial necrosis and damage. So we're getting into the realm then of a typical acute myocardial infarct.
So what about the evidence for revascularisation in terms of randomised control trial evidence of troponin positive compared to troponin negative stable patients?
In terms of stenting?
Yeah.
Well, we know that in acute infarcts and non-ST elevation infarcts, that stenting reduces further myocardial infarcts and also reduces the rate of mortality as well.
Yeah. So we're not going to talk about that group because the evidence is 100% clear-cut. Troponin positive, unstable angina patients should be treated with revascularisation or an early invasive strategy. So that group, this discussion we're having today has got nothing to do with those. Those patients are at high risk of death, myocardial infarction, and should be treated with an early invasive strategy. The group we're talking about today is this group down here. This group down here, the troponin negative, possibly stable patients. So the latest iteration in this is, if you put it in context, revascularising stable coronary disease has never really been shown to prevent death or myocardial infarction, not even bypass surgery. I mean, there's some early bypass surgery trials which have their own flaws, and if they were done today, they might have been done a bit differently. But it's very difficult to demonstrate that revascularising stable coronary disease, whether it be with angioplasty or even bypass surgery, except very distinct subgroups of patients, prevents heart attacks. So, we don't really talk about revascularising for preventing adverse events anymore. It's more about relieving symptoms. And this is where, I don't know if, has anyone heard of this trial in the audience? The cardiologists would have, but the Orbiter trial has been in the media. It was a trial that was published in The Lancet, and there was an accompanying editorial that was quite inflammatory for interventional cardiologists, and the title of the editorial was, "Is this the last nail in the coffin for stenting for stable coronary disease?" Because what we're trying to do now is demonstrate whether there is a symptomatic benefit in treating coronary disease with angioplasty. And this was a brilliantly designed study in the UK. And no study is perfect. It was a relatively small trial, but I don't know how they pulled it off in the UK, but they managed to do a sham placebo compared to intervention trial. So in other words, patients that had angina and positive stress echoes were put on the table, on the cath lab table, and listened to music so they couldn't tell what was happening, and they were sedated, and half the patients got a puncture in their groin and had nothing done. It was just a sham procedure. And the other half got a stent for their severe stenosis. So the patients didn't know whether they both had the same post-procedural care, so there was no way for the patient to be able to tell whether they had a stent or not. Now, obviously, the person that put the stent in knew, but he wasn't involved in the follow-up of the patients. The doctors that were involved in the follow-up of the patients didn't know whether the patient had a stent or not either. So it's a beautiful trial to assess efficacy of revascularising stable coronary disease. Because what the hypothesis was to try and look to see if there was an increase in exercise time more than placebo in the interventional arm. And so that was really the primary endpoint of the trial, is exercise duration on stress testing. And they powered the study to look for a modest increase in exercise time of 30 seconds on a treadmill. And in actual fact, the exercise time in those patients that had an intervention didn't really increase that much compared to the sham patients. So even though some of these patients had a 70-80% blockage and it got opened up with angioplasty, their exercise time didn't really improve that much. So there's a few... is there anyone that's familiar with the trial? Damien, have you looked at some of the data on that trial that might shed some light as to why that might be?
I don't know. My knowledge on the overall trial is not as good as what it would be.
Would you expect, at an intuitive level, when a patient has a stenotic lesion, that their chest pain would completely resolve, for example, after reopening the artery?
Resolve, maybe not, but improve most definitely. And I think anecdotally, I'm sure all of us have referred patients for coronary angiography plus minus PCI for symptom benefit and have seen significant improvement. So I think the results of this trial were extremely surprising to the whole cardiology community, except for the disbelievers out there for percutaneous coronary intervention in stable angina. But I think with every cardiology trial that proves one thing, there's another one that disproves it. So I'm pretty sure that we're soon going to get onto a different trial, which might be called FAME2, which will hopefully support the use of PCI in some of these patients.
So
Alex,
Pete-
I'll just ask Alex, if a patient has an 80% mid-LAD stenosis and you put a stent in them, and then a week later they ring you up and they say, oh, I've got some chest pain, it woke me up last night, and they ring you up, the secretary says, oh, can you ring up John Smith? He did a stent on him last week and he wants to know what to do about this chest pain. What do you tell the patient?
John Smith's a pain in the arse, actually. Really, the John Smiths of the world. So after I stent, I'd tell all patients that 90% will experience chest pains within the first 4 to 6 weeks. So I say to everyone before they go, you will likely experience fleeting pains across your chest. Sometimes it's a bit like a phantom pain.
Just to interrupt you,
Yeah,
why do you tell them that?
because I've seen it enough.
Why are you confident that it's not angina?
It's a different pattern to what the usual pain is.
And you put a stent in, you fix the artery, right?
Yeah. So I'll say to them, my expectation is that if they have a clear and typical pattern of angina, I think it's important to differentiate that. So I say to patients, and if we can go across a bit broader here, I'll say, look, I stent for 2 reasons: to stop a heart attack happening at the time or to relieve symptoms. But I'm always very specific that there are symptoms that you're confident that are going to be relieved, isn't there? And they're the symptoms that when people come and say to you, look, every time I walk up the hill, I get tightness in my chest, I get short of breath, and I'll say to them, look, I'm going to put a stent in here and that's going to go. But there are patients that possibly that I get referred to that I'll do, but I won't be convinced that's necessarily symptomatic at the time. And someone will say, and I'll say to them, look, I don't suspect that you're necessarily going to feel any better, but this is potentially going to save either you having a heart attack or potentially developing symptoms. So it really depends on a baseline symptoms.
What Alex is saying, the patient had an 80% blockage, he put a stent in them, they had a good result. A week later, the patient rings up, they've got chest pain. He says, don't worry about it, get on with your life. Pain goes away, you never hear about it. So Charles, let's look at another one. So you're the imaging doctor, you've just done a stress echo on a patient, and the whole LAD territory is ischemic. The patient disappears, and you don't know whether they've had a stent or not. It may well be that they've still got an 80% blockage and the LAD territory is ischemic. The patient rings up your office and says, I woke up last night with chest pain. Can you ask Dr. Charles Chow what I should do about it? How would you react to that? The patient's got an 80% LAD lesion. the LAD territory is ischemic, but you don't know whether they've had a stent or not.
I'll get him to hospital. I need to see him. So he'll go through emergency and we'll have the standard workup. I mean, it would depend on what his ECG looks like, what is the pattern of pain, duration of pain, and also what his troponin assays show. I guess the question is, because we know that there is significant ischemia, we don't know whether that stable plaque has just become unstable, or whether he's had a procedure elsewhere that we didn't know about, and this is just one of those fleeting pains. So given that we don't know the stent has been placed, we'll assess this patient.
Okay. So that patient, so Alex's patient is reassured, he's happy, his pain's gone away. Charles's patient, he's panicking. You know, Charles is telling him he might have a heart attack, he's probably going to drop dead. So he's calling 000 and goes off to the hospital. So there is actually a term for that. Has anyone been keeping up with what's been happening in Orbiter and the relief of pain after revascularisation? There is actually a term that they've coined called faith healing. And does anyone understand what faith healing is? You do it all the time in your GP practice. Does anyone practice faith healing in general practice? Yeah, tell us about faith healing.
Well, it's a multifactorial thing. One of it is your approach to the patient, whether you establish good rapport and you put them at ease, but not put them to the extent that you deny them the true nature of their condition and the results of it. But you do it in such a way that you have this good rapport and you communicate with them in terms they can understand. And that's all part of it. And keep coming back if they understand what you're saying. And after all, if a philosopher wants to communicate with a moo, with a cow, he has to say moo. So it's no good talking philosophy to a cow. You have to say moo. So if you want to convey what you're trying to get across to the patient, you have to say it in terms they understand. All this is part of faith healing, I'm sure. I mean, I don't have chicken blood and moonlight and circles of stones, but
Correct, and that's the key. So does anyone else practice faith healing? We do it all the time. That's called reassurance. We're different to witch doctors. We're different to homeopaths. It's not. It's faith healing is part of medicine. Margaret, were you going to make a comment? Do you practice faith healing, Margaret? Yep. Does anyone else understand what that is? So I do faith healing every day when I'm in the cath lab. If I open up an 80% blockage, I make sure that the before and after picture is as good as it can be. And I say to I'll put it in front of them, look at this, 80% blockage. It was terrible, you were nearly going to die, and this is what it looks like now. It's like a highway, you can drive a bus through it. You're not going to have chest pain again, it's all fixed.
Spoken like a true charlatan. I just want to draw you out a bit here, because in terms of the patient presenting with chest pain, I mean, what we haven't actually talked about is the chest pain, right? You know, because the assumption here is that the chest pain is ischemic.
Yes,
that the chest pain is due to unstable angina, threatened vessel occlusion. Could it be due to little microvascular events due to some early plaque instability with, thrombotic debris heading down, which is the milieu of the acute coronary syndrome, I suppose? Or is it non-cardiac chest pain in someone with heightened awareness and sensitivity subsequent to an intervention? So, I mean, I do think you've got to focus a bit on the characteristics of the pain, the nature of the pain, the circumstances, the probabilities, and those sort of things come into the clinical assessment, of the circumstance, which is what Alex is probably doing on the telephone, because he's taken those sort of things into consideration. Yeah.
Absolutely, and I'm not. I'm sort of intentionally controversial because that's the debate that's actually going on at the moment in this sham trial, that in fact the patient's expectations and the doctor's ability to assess the chest pain was influenced by the fact that they didn't know whether the blockage was fixed or not.
Peter, in that trial, do you know what the baseline
stress test time was?
Yeah, that, yeah.
Was that the one
It was,
8 minutes or something?
yeah, it was 8 minutes, so they were pretty.
I don't know, did the echo guys want to comment? Like 8 minutes on a treadmill for someone who's got an 80% stenosis. I mean, it's pretty good, isn't it? I
Yes,
mean,
it is. Yeah, and again, from pure stress testing, prognostic data, like in the era before stress echo, you'd think 8 minutes, it's not bad. And even if they were ischemic, it's a high ischemic threshold, and in a era before a willingness to revascularise everything, medical therapy, we'll see how it goes, wouldn't be unusual. The other thing I want to come back, and Damien wants to say something, but in terms of the Orbiter trial, I think it's like all good trials, they don't answer any questions at all, they raise questions, And I suppose, and this has been howled down by everyone, but the main thing is it asks important questions about the rationale of what we do, which is what you're discussing now. But some of the endpoints, for instance, first of all, it was a fairly short trial. The follow-up was quite brief, and it was measured in months. It wasn't measured in years. It was a fairly small series, as you might expect from a sham trial. But I think the other thing is if you're using treadmill exercise duration as a marker, the first thing is that everyone gets better with their second stress test. People learn how to walk on treadmills. And if you're using the duration of exercise as a marker, well, all you have to do is do another test. And most people improve to some extent.
That's the placebo group, yep.
Can I ask, Peter, in the Orbiter, did they actually separate the location of the disease? Because if you can imagine a patient that comes in with a 90% mid-LAD stenosis supplying a relatively large amount of myocardium, if you opened up that vessel, you'd expect a more significant improvement in their physical capabilities compared to someone that had, say, a very distal stenosis. Did they actually look at that?
No, I think that those sort of subtleties or sub-analyses, they're in the pipeline. They're going to hopefully present all that information with FFR data. So the initial trial was purely the presentation of all outcomes, and this is really the key slide along with that we know so far from the trial is the exercise duration and symptom relief.
Well, because I think the location is vital. Because if we look at what we do clinically anyway at the moment, if we had a patient that had stable symptoms and had a distal stenosis, you would, without a shadow of a doubt, go forward medical therapy first until you failed with medical therapy, and then your only alternative would be to think about PCI. Whereas if you had a patient that had a proximal or mid-LAD stenosis supplying a large amount of myocardium, I'll be more inclined to push towards early PCI, because I know, first of all, for potential symptomatic benefit, but also a lot of these patients, for peace of mind, if they know they've got a severe narrowing in one of their coronaries, then a lot of them stop doing what they would normally do in their activities of daily living, and that's not what you want to achieve. We also want these patients to keep on potentially exercising, because if you don't, their other risk factors are going to go out of control. They're going to put on weight, their blood pressure is going to go up, their cholesterol is going to deteriorate. And yes, we can push medical therapy toward blue in the face, but from what I've seen from patients that have a known stenosis, particularly when it's in a relatively major artery, they all will feel much better in themselves if they end up having it fixed.
And that was one of my key criticisms with, I've sort of been able to engage with some of these authors, and with social media now you can actually talk to the authors and ask them these questions, and Damien's questions are precisely the questions that I've asked. Is sure, there's this concept of faith healing, but there's also the concept of the patient, number one, wanting to know whether the chest pain is cardiac or not. It makes a difference. Now he's saying, Professor Francis, who published this, he's saying it doesn't matter whether it's angina or not. So he's saying if the patient's expectation is irrelevant whether the chest pain is angina or not, because we're not dealing with unstable angina. So whether it's cardiac or non-cardiac is not relevant. It's really whether the patient wants their symptoms relieved. The problem is you can't label it. So here, all these patients had abnormal stress echoes. So post-intervention, they all had negative stress echoes. So they all had their ischemia objectively. It was all of them, 100% of them had completely normal stress echo. But it's a bit like the rehab program that we run. at some of the hospitals, the nurses ring up the patients to see how they are, and most of them will say they've had some funny chest pain. But if you don't know whether the vessel is revascularised, it's hard to tell, it's hard to reassure them. Let's just move on. There's one other concept. So there's the faith healing concept of reassuring patients, and I actually think we do that all the time as doctors. That's part of clinical experience, being able to look at the patient in the eye and say, you don't have cancer, you know, you don't have a heart attack.
Put some comments and just open this trial. So it's actually a very small number, it's only
200
200.
patients, but it was powered adequately for.
200 patients, some of them with small vessel disease, often diagonal, often marginal. We don't expect it to have any changes like this. So it's actually a very small amount, probably have very severe proximal, let's say, LABs and also which could have the impact of the stress test as such. Because look what we found very often within the stress echocardiogram, stress test, we find this is small lesions, no joint branch or diagonal branch, not so much changes.
Absolutely, Ischaemic. These guys are used to looking at trials, and it's important to be able to look at trials critically, and everyone has made the same point. Malcolm and Damien and Alex and Ischaemic, those points that you're raising are the points that have been raised. It's a small trial, small follow-up, 200 patients. It doesn't apply to everybody. Patients' expectations about being able to get on with their life, not wanting to be on 5 pills, not wanting to see a cardiologist 3 times a week. And this is the key thing about randomised controlled trials. Randomised controlled trials give you general impressions about how some patients might behave, but it doesn't tell you how you're going to manage that patient that's sitting in front of you face to face. So it's very good for people writing guidelines, probably not so good for you and I that are clinicians. Just one more concept before we move on. So there's the concept of faith healing. Now there's another concept that's been introduced in this trial, and that's what's called subtraction anxiety. We saw subtraction anxiety in FAME 2 trial and Courage, where you get a lot of crossovers through the trial. So in other words, in those trials, they had an angiogram and they found an 80% blockage in the LAD, and then they got randomised to medical therapy or stenting. Now, what do you think happened to the ones that were randomised to medical therapy? They knew they had an 80% blockage.
They wanted a stent.
They wanted a stent, exactly. So what happened to them? They
waited until the time was up and asked for
Yeah, or rang up the hospital and said, I'm getting chest pain, rang 000, went to the hospital, and they labelled them as unstable angina and crossed over. So the problem with Courage, which is the other big trial that, and I don't want to sort of confuse this, but there's only 3 real major trials in cardiology lately, and that's the Courage trial, FAME 2 and Orbiter. The problem with Courage, it showed that there's no mortality difference between medical therapy and stents, with the caveat that most of the patients in medical therapy actually crossed over and got an intervention. And you're allowed to do that in an intention to treat analysis. So Courage told us that an initial strategy of medical therapy is reasonable, but that doesn't mean that medical therapy is maintained for the rest of the life of the patient. They actually cross over. And I rang up Darryl Francis, who published that Orbiter trial, and I said to him, what happened to your patients when they got out of the trial? You know, the sham patients that didn't know whether they had a stent or not. What do you think happened to all those patients that were treated medically, Charles, after the end of the trial? Sorry, it's a loaded question with an obvious answer, but once they found out that they had an 80% blockage and it wasn't stented, what do you think happened to them?
Same, they started getting chest pains.
Yeah, they started getting chest pain and they all crossed over and got stents. So,
it overlaps a lot with general randomised controlled trials that have been done. What you really need are large randomised controlled trials. They're getting more and more expensive, so it's difficult to do them. But the really important trials of guided medical therapy involve not 200 patients, but 2,000 patients. Think of the beta blocker trials, the important ones with sudden cardiac arrest that I mentioned earlier. They were very highly powered in terms of numbers. You have to have careful patient selection. Now, just having somebody with chest pain doesn't mean that they all had angina, so you're already diluting your 200 because some of them may not have had cardiac chest pain. you're using a weak endpoint by just doing a stress echo in that some of these patients will continue, some of the patients who had a significant lesion may not have had a stress echo, so you wouldn't expect that they will necessarily go further, and those who had a positive stress echo and then had sham treatment may still exercise longer even though they're still getting chest pain. You've got a highly variable sort of endpoint in terms of interpretation. It's not a hard data endpoint like death or
Yes.
might have on Parkinson.
Yep.
So I think what you need for randomised trials to really answer these questions is a lot of patients asking a very specific question and making sure that all your entry patients have that criteria, and then having a very strong endpoint. And I think that's where this falls down on basically all of those counts.
They say some clinicians, and that's that sort of nuanced comment that Wayne just made is absolutely spot on of what's going on with this debate at the moment. Is how to apply and how to perform a randomised controlled trial that's meaningful. The other big deal is enrolment, and we now say you can't really do a randomised controlled trial unless there is equipoise. In other words, you don't know which treatment strategy works better. So you've got you've got stents, you've got medical therapy. We don't know, and you can only do it in a place where you can't get access to a pre-existing bias towards a treatment, because there is what we call enrolment bias. So if you turned up at St Andrew's Hospital or in another hospital and with stable exertional angina, and I did an angiogram on you and found a 90% blockage at the ostium of the LAD, how many of you would want to be randomised in a trial where there is a 50% chance that you'll get medical therapy? Now, some might, but there is a bias at the patient level and there's a bias at the clinician level in enrolling those patients. So the randomised controlled trial can't tell us who was subconsciously not enrolled in the trial because of physician and patient bias. That's why you can't apply the results to everybody.
Comes back to cancer analogy, doesn't it? I mean, there's a primitive urge. If I have a cancer, I want it out.
Yes.
If I have a stenosis, I want it opened. It's a primitive.
It's an absolutely perfect analogy, because there are all these screening tests that we do now to detect cancer at an early stage, but we don't really have a lot of randomised trial evidence to suggest that picking up those cancers at an early stage is actually helping the patients live longer. And there are a couple of good examples about that you guys would know better than me, but that's actually under the pump at the moment, is screening testing for cancer. Is it really saving lives? And is it as cost effective as it? And it's not it's a very, very pertinent question.
You have an ethical facet here too, don't you? That when you're selecting these people, and some of them you know that are most likely to benefit from one treatment to the other, but you still randomly place them. You may well be doing them a disservice.
So when they talk about equipoise, a true equipoise is when there is no evidence that one treatment is better than the other. That's the only way you can get the randomised controlled trial through an ethics committee. If there's no true equipoise, you can't do it. Otherwise, that's just using people like guinea pigs. But you can have equipoise, and you have clinician biases and patient bias based on the fact that the procedure's been around for such a long time that it's accepted. And then you try and do a randomised controlled trial, but it's littered with biases in enrolment.
On the topic of chest pain and anxiety, I've got a question. Has panic and anxiety disorder comes in with crushing central chest pain, sweating, nausea, recurrent fantasy? What's the mechanism, and more importantly, what's the significance of episodes?
Okay, let's ask, shall we pick on Damien? Okay, I had another slide coming up later on, but we'll discuss it now that you brought it up. Damien, as an interventional cardiologist, I've been brought up that the angiogram is the gold standard, and if the stress test tells me that it's abnormal, and I do an angiogram and there's no obstructive disease, then we say, oh, it's a BS stress echo, it was a false positive. Now, is there such a thing? So, and this is I'd like you to sort of drill down on that because I think it's a big area. Is there such a thing as a false positive stress echo, or is it a false positive angiogram? And can you tell us the difference between the two and how that relates to the patient's chest pain?
Well, it's a good question. It's quite commonly described, or a number of people will describe it as being a false positive stress echo, but that is not true. Okay, so you can't get a false positive stress echo. You can get an equivocal stress echo. Say if the endocardial definition, you can't see the borders as well as what you'd like to, then you can say there's a suspicion of ischemia in that territory, and you know, if the angiogram was normal then, but if you can clearly see the endocardium, you can still get changes in the myocardium despite the coronaries being okay. The prime example being microvascular dysfunction. Okay, if you've got a diabetic, certainly some older females, they can get apical regional wall motion abnormalities with having perfectly normal coronary arteries. Okay, and that's due to microvascular dysfunction. As a matter of fact, we did a paper looking at purely that cohort of patients, and if you do a first test of a stress echo in an episode of chest pain, if they purely have isolated apical regionals, so very limited amount of ischemia, a lot of people say, well, that's going to be a non-prognostic disease, we're going to treat these patients medically. But what we actually found in London was that between 15 to 20% of those patients over the next 2 to 3 years will have percutaneous coronary intervention. Okay, so they will require a stent down the track. So when I report a stress echo that describes apical regionals alone, I will describe it as being this likely will reflect microvascular dysfunction. However, obstructive coronary artery disease cannot be excluded on this test. Does that answer your question?
Yeah. So, Alex, can you elaborate that based on our ability to assess ischemia angiographically and anatomically based on the angiographic findings and how we're sort of dealing with that at the moment? Are we very good at predicting whether a lesion is ischemic and correlating it with?
No, angiographically we can't, is the simple answer. Just in terms of your patient that presents with the chest pain and diaphoretic symptoms, I think there are a number of possibilities, aren't there? I think that's what Damien was saying, and Peter, that we've got microvascular dysfunction, we've got all sorts of different patterns. When we were registrars and we do an angiogram on a patient with chest pain and the angiogram was normal, we would say to them, your chest pain is not coming from your heart. And we now realise, flashing forward 20 odd years, that was completely wrong, that there are people who have what we call angina with angiographically normal coronary arteries. So I think when you see your patient who's got anxiety, it's important to take a history in terms of when they get their pains. And if they can go and run 5 kilometres every day and don't get any symptoms, but when they're sitting there alone in the dark and they start to worry about something, they get their symptoms, and it might not necessarily be cardiac, but similar, I guess, reaction to that. But back, in terms of when we're in the lab and we do an angiogram and the arteries are normal, no, we can't tell whether there's an ischemia. We don't do provocative testing for people now in terms of coronary vasospasm, which is another reason why people get pain with normal coronary arteries. We now do hemodynamic testing in the cath lab, so I think if that's what you might be referring to, where we put a pressure wire down the artery and essentially measure the drop in blood pressure when the blood flows across an area of plaque buildup with specific cut-offs in terms of flow. So that's probably the best way of determining whether a person might have ischemia secondary to a specific stenosis. We also use imaging, so intravascular ultrasound and optical coherence tomography, which gives us some clues to the makeup of plaque in the arteries, which might give us some clues as to whether that plaque might potentially be unstable. I guess further down the track, in terms of Peter's question about can we tell whether that plaque is vulnerable or unstable, we might start to get into thermography, where we can do, where you're looking for the person that's lost in the ocean and you put on the infrared. We might start to do that in terms of looking at plaque to see whether there are temperature changes within the plaque that might detect that.
I might just move on because there's quite a few big chunks that we need to cover. and we've only got about half an hour. So let's get back to our patient. So with all that contextual information in mind, so he wants to be screened. So what does that mean? What are we screening for? So what's the essence of it? What's the essence of screening in ischemic heart disease? I mean, with cancer, is you want to know whether you've got cancer or not. But with ischemic heart disease, what's the essence of it? What does it boil down to? Maybe. I mean, having a stenosis, I can have a stenosis. If I'm 100 years old and I have a stenosis, it doesn't worry me. Correct. Who said that? Yep. So if a patient comes to see me and they're a colleague or a friend or somebody or any of your patients, and they're in front of me and they say, I want to be screened, I don't want that patient to drop dead and I don't want them to have a heart attack. They can have the worst coronary arteries in the world, but if they live to 100 without a heart attack, it doesn't matter. All I'm interested in is that I don't want them to have a heart attack and I don't want them to die. So when you're screening for coronary disease, that's really what you're trying to prevent. So we're preventing myocardial infarction, we're preventing death, or trying to, by treating risk factors. So screening for coronary disease, I hate the term screening because we're not really screening like that. It's really a risk stratification algorithm. And just kind of think of it like that. And that brings us to the next question of how best to avoid death and myocardial infarction. So let me just make an inflammatory comment that if we want to prevent death and myocardial infarction, the best way to do that is to take a statin. Okay? So bearing that in mind, is everyone in the audience here and on the panel on a statin? And if not, why not? So let's ask the experts first. Damien, are you on a statin? And if you're not on a statin, why not? And can you generalise with the general population?
No, I'm not on a statin. Currently, I'm a great believer in using statins, but I'm in particular a bigger believer in using a healthy diet, in particular the Mediterranean-style diet. However, we're going to talk about statins now. Will I be on a statin? It's a very good question. I was at a conference about 3 years ago where there was a room full of cardiologists and the lecturer asked the audience the same question. And it was a room full of cardiologists from mid-late 30s all the way up to 70s, 80s. And I think about 2/3 of the room stood up when they were asked if they're on a statin or not. And I'm pretty sure they didn't have cholesterols of 8 or 9.
Let's do a quick poll. Who is not on a statin? Okay, have a look at that slide. Everyone have a look at that slide that's on the board now. It's a very busy slide, but it's a brilliant statistical analysis. And there is, if you look through that, I mean, just to simplify, and I don't ask me statistical analysis because I don't really understand how it was determined, but every trial that was done on statins that was a good quality trial was included in this meta-analysis, and they looked at the hazard ratios or risk reduction in each category that you can imagine. So going down the list is all the subsets of patients. So irrespective of what subset the patient is in, whether you look at diabetes, hypertension, age, hypertension, body mass index, LDL levels, smoking status, renal, all these variables, they all have exactly the same risk reduction. So the risk reduction you get with a statin is the same, irrespective of what patient you're looking at. That's pretty extreme extrapolation to make that everybody should be on a statin, but there is no group in that sub-analysis up to this point that's been identified that's not going to get a risk reduction of at least 0.75 on the hazard ratios that they calculated. So why wouldn't you put everybody on a statin?
Well, see, Damien's thinks that driving safely prevents us car accidents, you see. And, so other people want airbags and some want seat belts.
Have a look at that slide, Malcolm. That's the slide that Malcolm is talking about. So what does that tell you? What saves more lives? Seatbelts or putting the whole population on statins? And which one is more expensive? So I want you to tell me I want to know why you wouldn't put that, metaphorically, why wouldn't we put a statin in the water supply? Why don't we do that?
Side effects.
So Lipitor,
Side effects.
Lipitor is off patent, right? So technically it should cost about 5 cents a tablet to take. So why wouldn't, and let's have some opposing views, but why wouldn't everybody be on a statin? Is there a reason?
Side effects, Peter. The side effects of statin therapy.
Side effects, yeah, and what are those?
So, in particular, the things that people get particularly worried about is rhabdomyolysis. Now, there's a big distinction between generalised muscle aches and pains and rhabdomyolysis. Obviously, muscle aches and pains are very common with statin therapy, whereas rhabdo is not.
1 in 15,000 people.
1 in 15,000? That's pretty uncommon.
Peter, are you on a statin?
Yes.
Yeah, good.
So let's talk about side effects. So you have a patient that's come to see you, and hypothetically they do need a statin, and you're about to put them on a statin, and they ask you, what are the side effects? So what do you tell them? If you look up MIMS, do you tell them everything that's in MIMS, or do you tell them there are no side effects, and is that ethically appropriate to say that? So what do most of you say? If I'm a patient and I come to see you and you want to put me on Crestor, and I say, well, I keep reading about all these side effects. Are there any side effects? What do you tell them, Evan?
Not.
A statistical concept of how common these side effects are.
Are there any side effects from statins?
Yes, there are.
What are they?
Some people, it upsets their livers, their liver enzymes go up, they may get muscle aches and pains, they may find their liver enzymes shooting up, it may be severe enough that it affects
Okay, here's another inflammatory table, and this is also a meta-analysis of the side effect profile on patients with statins and not on statins. And in actual fact, and these are sort of merging with the nocebo trials that are now being done on statins. And in fact, if you believe the data, the only significant difference between statin users and non-statin users in terms of side effects is that there is a small number of patients that will upscale from being non-diabetic to diabetic. And that's the one that's highlighted in yellow. Everything else is no difference in the statin group compared to the non-statin group. Even rhabdomyolysis, if you look down the bottom, occurs at the same frequency. The p-value is irrelevant, it's 0.9. The hazard ratio of side effects, real side effects, not BS side effects, is exactly the same in the statin group on this meta-analysis in the non-statin group.
I think you've been highly controversial, Peter, but look, I'm with you on this, because I tell people that there's a 97% chance they'll have no side effects at all. That's what I say. So I focus on the upside, not the downside. And I tell them that the most common side effects are things that people get anyway, which is muscle aches and pains, and a small percentage of people get genuine statin-related myalgia. And it turns out, in my experience, it's a tiny percent of people who are genuinely, seriously statin intolerant. And what you'll see is statin pseudo-intolerant individuals who then discover they've got coronary artery disease, who've just had a bypass operation. The vast majority of those will translate into statin tolerant or statin relatively tolerant individuals. But, there's still, maybe 1%, maybe 1.5% of people who are genuinely incapable of taking statins. And for them, the outcomes are very different, right? And you've got to highlight that too, I think.
It's quite I'm intentionally inflammatory because I think it's quite an emotive area that's not necessarily based on science. And these are these amazing nocebo trials that are being done now about putting patients on a pill and not telling them whether it's a statin or not, and monitoring to see what the side effect profile is. So say hypothetically, this patient that we presented
studies from all over the place on different subsets of patients. But it's not the same as taking the random general population and doing a clear, large-scale randomised controlled trial. And there's plenty of examples where meta-analyses have been wrong when some sort of randomised controlled trial has been done. And I can name a few of those, but that doesn't matter. It certainly has been shown. And what I would argue is that that would suggest that there's a hypothesis that statins for everyone would be a good thing, but it's not quite the same as having the proof. And that's why I think that we should all take statins, and that it's more a clinical decision based on your risk factor profile and age and all that, sort of general clinical things. So if you've got a 90-year-old who's never had an infarct, they can have a high cholesterol, but you'd be very hard pushed to say that they're going to have improved survival by putting them on a statin at that stage. So I think it still remains a clinical trial, and a clinical decision. And I think we have to be careful when we look at meta-analyses not to confuse that with being absolute clinical data that's unchallengeable. So it looks very good hypothesis, but if you really wanted to prove that, you should take sort of 100,000 people
and follow them
or
up.
more,
And that's the key, large numbers.
Many, because a number of those would be high-risk patients, and you'd have to include plenty of low-risk patients in order to really answer that question.
Yep, I agree. Totally. I think that's... thank you. So,
Can I make a quick note as well? Sorry.
Can I just move on? Sorry. Just one quick question, because we've got to move on. There's a lot of stuff. Ooh, okay. Here's the deal. I'll show you the deal. Here's the deal that you've got to make with the patient. So if you drill down to the statistics, and with the reservations that Wayne is succinctly and eloquently put out, if you treat 1,000 patients, this is primary prevention. I'm not talking about secondary prevention because that's a no-brainer. But in primary prevention, treating 1,000 patients, 90% of them will not benefit. And you can't really pick which ones are not going to benefit. And 70% of those will end up dying from other causes, cancer or whatever. And about roughly 10% will take a statin, but they would have benefited, but they didn't, and they died anyway. So there's a 10% chance out of the 1,000 that if you take a statin, you will live 5 to 10 years longer than you would have had you not taken the statin. So out of 100 people, 1 in 10 will, so there's 100 people in this room, well, maybe more. So 1 in 10, if you all take a statin, 1 in 10 of you will live longer, and the average length is about 5 to 10 years longer. So if somebody gives you odds of 1 in 10, I mean, you can bet on 1 in 10 and probably think that's a reasonable odds. But if somebody told you there's a 1 in 10 chance if you take this pill, that's the extreme sort of view. But that's the statistics that you can deduct from that. I just want to move on because it's important to. Sorry, we just got to cover some of these points because we're going to run out of time. So say Charles, this patient, he's one of these patients that's not really keen to take a statin. He doesn't really. He's read the New York Times and he's read the Courier Mail about all the side effects, and he says, I really want to go on the Mediterranean diet. You know, Damien Rope is a friend of mine, and he keeps telling me if I drink lots of olive oil and change my name with an OU at the end of it, it'll be fine. Charles, is there anything you can do to convince this patient to take a statin?
So with the available information, you'll be able to use the risk calculators that's available to risk stratify him, to let him know whether he sits.
Okay, I plugged it in, sorry to interrupt, I plugged it into I can't remember which one I used, I think it was the MESA one, and it came out at, using those clinical variables, it came out at 3.5%.
So he'd be in a low risk group. So of course the question that he's coming to, he's probably already know he's low risk group, but he wanted to know whether he's truly the low risk group or whether there's other things that, there's unknowns. So the test I'll be able to offer him, not to say that he definitely have to have the test, is to look at his plaque burden And the only test that we can really do is non-invasively CT scan. And there's only 2 tests we can do in terms of CT from the cardiac point of view. One is CT coronary angiogram and one is CT calcium score. And in terms of screening or risk stratification, coronary calcium score would be the test to pick. And that would give you not only a number, but also give you amount of plaque to assess plaque burden, and then also be able to give him a guide as to what is an age-appropriate plaque.
So he's gone for the CT calcium score. Sorry,
Can I just say, he's low risk, right? So he's 3.6%. Even if his calcium score's high, right, let's say it's 200, he's actually still low risk. You know, it jumps, it doubles. He'll go up to 7.5%. On that, but because the rest of the risk profile is good, even a moderately high calcium score at 54, and the risk score is for 10 years. It's a 10-year risk. The MEAS are calculated, so you're looking at a 10-year risk. He's going to go from 3.4 to let's say 8.4 or something like that. So he becomes somewhat intermediate, but he doesn't actually jump to high risk because he's still protected by youth, which is 54. He just hasn't lived long enough to get bad stuff, right? Purely on a risk.
Is that right, Charles? Even if he has a high calcium score, he's still low risk?
Because he's young, it just means he's got more time to get heart attacks. He's got another 30 years potentially getting multiple heart attacks. I guess you haven't seen the pictures yet. He's got plenty of plaque in the OAD. So overall, his risk is still going to be lower compared to someone who's 70 or 80 with higher risk profile. But in comparison to someone of his age group at early 50s, his risk is a lot higher. And that's where you see in terms of the percentile chart, in terms of they may have a 200 calcium score in a 50-year-old is different to a 200 calcium score of a 70-year-old or 90-year-old, because relative to people of their age group, they are proportionally at a higher risk group. And in terms of absolute risk numbers, as what Malcolm said, is that it doesn't, having a calcium score of 200 age of 50, it's a different risk to someone who's 75 who's diabetic and have a calcium score of 200. They still, the other risk comes in as well.
I'm going to race along. That's the calcium up there. Charles knows exactly what's going on there. There's lots of plaque everywhere, but for us interventional cardiologists, we can't interpret it unless there's colour, which is why they do these CT calcium scores and they colour them in, and they put circles around them too. So you can see the circumflex, the LAD and the right all have calcium in them. So
the potential difference in him is because of the calculator counts as a low risk, that he would either continue with lifestyle and dietary modification if his calcium score is low or zero, whereas if he's got significant coronary calcification, it'll push the individual more likely to be on a statin.
So here's the curve, Charles. Sorry I took that on my iPhone. I didn't have time to do scanning. So I don't know if you can see it. That's his percentile chart. So can you tell us about that?
What's his score? 720.
His score is 721.
So he'd be over 95%.
And the red dot is where he is on the chart. Can you see that, Charles? He's above the 90th percentile.
He'd be over 90 percentile. So he has got significant plaque. I mean, even by plaque burden, usually the low burden of plaque is less than 100. Intermediate sort of 100 to 400. 400 to 1,000 is high, quite a lot of plaque, and more than 1,000 is quite a lot of plaque. So he has got significant plaque.
Here's the distribution.
He has got significant plaque burden for his age, and usually at the age of early 50, that's when people cross over from males from 0 to score of 1 in that 52, 53 age group. Female has a 10-year lag, so female crossover in their early 60s. That's why they live longer.
Let's just stick with Charles for a moment. He's the expert in this. He does this every day. Now, this patient, he's got this result back, and we've got to deal with the emotional trauma after you've given them this test, Charles. So he's looked at that, calcium score 721. Sometimes you guys give them an arterial age, which is horrible. They write that down, they're 85 years or something, and they said, oh no, I've only got 2 years to live. what do you tell him now, based on that, and what do you do next?
So I go through the images with him and explain to him in terms of where the plaques are, and certainly based on the CT calcium score and the plaque that we're seeing, that he has got significant plaque burden. That's not to say that he has got coronary artery stenosis, but it does certainly pushes his risk up from the 3.6% previously calculated based on the known risks. This is probably going to be driven by his genetics, because it's something that you don't get to see, whereas calcium score just lays all the plaque out there in front of your eyes. The most important thing in terms of is getting him some treatment, medical therapy, and that will involve statins and aspirin. Of course, the next step will be to work out in terms of is he truly asymptomatic, does appears to be, exercise regularly, and asymptomatic. But given he's over the 90th percentile for his age, I would offer him an exercise stress echo, assess his LV function, and see whether there's any areas of inducible ischemia. There'll be two outcomes. It'll be the normal or abnormal, and if it's normal, then continue with medical therapy. If it's abnormal, then I would offer him a coronary angiogram.
That's precisely the question they ask when they get the calcium score back, is the prognostic significance, or the probability that they have prognostically significant disease. And Charles, you can tell us about the data, but there are good data now on calcium scoring and plaque burden in terms of longitudinal prognosis, but also in the increased likelihood of predicting underlying ischemia. So in other words, the more plaque there is, the more likely, and it kind of makes sense, that the more likely it is that they'll have an ischemically significant stenosis. Now, based on that information, he had the option of having a stress echo and a CT. He wanted to know what the coronary anatomy was now, and he self-referred, being a medical practitioner, he self-referred for a CT coronary angiogram. Okay, and what would you think about a CT coronary angiogram, Charles, in a patient with a CT calcium score of 720? Now, the reason he wanted it is because the calcium was, you might remember from the previous slide, was pretty evenly distributed in the major epicardial arteries, especially the LAD.
It's a bit tricky. I mean, first of all, to say is that if he's truly asymptomatic, this will not be covered by Medicare, so there'd be out-of-pocket expense. So it wouldn't be something that we would advise first up. But in terms of scanning people who's got higher calcium, it'd be used as a general. The best way is to look at the calcium score to give us an idea in terms of how likely we're going to get a diagnostic information. As a general rule, if the calcium score is over 1,000, the chance of us getting diagnostic images on the CTCA is lower because of the amount of calcium blooming. Now, the other thing, the reason why we want to look at the calcium score itself is what Peter mentioned. It depends on the distribution of the plaque. 720 could be equally distributed throughout the vessel, and hence the individual plaque burden at a particular spot is not particularly high, and we can still got a good chance to see through those. Whereas if you have 700 calcium score right at the left, like the LAD ostium or circumflex ostium, everything's concentrated there with a big chunk of calcium. We can see everything else, but not that part, and it's in a way sort of not a useful test. You might also just go for an invasive angiogram to clear that up. So the distribution of calcium is important, but we've got the CTC anyway.
So that's the circumflex, and we won't labour on that because it just shows a mild plaque in the mid-section of the circumflex. And Charles, sorry to put you on the spot, you haven't seen these pictures, but that's the right coronary artery, and I know you like looking at these in the axial planes, but that's the right coronary artery, reasonably representative of what was reported on the CT coronary angiogram. Can you just very briefly?
Yeah, so in the middle, so you can see in his plaque, apart from the bright spots of calcified plaque, which you already seen, that you can see areas of darkness. The dark plaque is what we're sort of more worried about. They're the soft plaque that you don't get to see on the coronary calcium score. They're the more rich, the lipid plaque. So he's got a both calcified and non-calcified plaque. In the middle there's a moderate stenosis, which is predominantly non-calcified.
So and that's the LAD?
The LAD is quite heavily calcified. You can't see through that amount of calcium. There's associated soft plaque that's distal to the all calcified bit, but it'll be non-diagnostic or highly suspicious there's something going on in there.
So the report was written that he had a suspicious lesion for a high-grade stenosis in the mid-LAD. It was extending to the proximal part of the LAD, and the right coronary artery was suspicious for a severe or moderately severe to severe lesion. So he came to see me at that point, and then this is the subtraction anxiety part of the assessment, where he comes with that in front of him, and I said to him, "Do you really have no chest pain?" And the answer was, "Well, sometimes when I'm operating and it's a stressful operation, I get this sort of vague tightness in my chest, and then when I've finished and it's a good outcome, it goes away. But when I'm exercising, I don't get that chest pain." So where to next from here, Damien?
I think that certainly referring for a stress echo would be a nice way of, first of all, looking for inducible ischemia, but also quantifying how much inducible ischemia he's got. Looking at his functional capacity. I think one thing that we get about symptoms is that it's relatively subjective. We get patients that come to see us who say they have no symptoms at all, but as a matter of fact, they're very sedentary. They don't do anything, so they never push themselves, so how do they know if they've got symptoms or not? This is a very nice way of quantifying their physical capabilities, and we can quite easily compare that to what we'd expect for someone of their height and age to be able to achieve. So in this case, I would be starting with a stress echo to see if I can provoke symptoms, as well as seeing if I can demonstrate inducible ischemia.
Yeah. And that's what Charles was saying about the positive predictive value of CT. It drops off. The more positive it is, the less specific it is. The more negative it is, the more accurate it is. So cardiac CT is good for ruling out coronary disease in low to intermediate risk. Sorry, I'm sorry. We'll just get onto some questions in a second. I just wanted to cover these really key things. So that's the stress test. So Malcolm, he got on the treadmill. In fact, he had a...
Looks bad, Pete.
He had a stress echo, but let's just say you don't know that he had a stress echo. That's the stress test. Can you tell us what that shows?
Well, I think I've seen the exercise duration. It's gone 8 minutes, I think, by the looks, which is, and I don't know whether that's a standard Bruce or an accelerated Bruce.
Standard Bruce.
Standard Bruce. So it's sort of moderately high workload. It's not fabulous workload. For a 54-year-old guy, I might expect him to go a bit longer than that, I might have thought. Alex would probably go, 12 to 14.
Actually, it might have been one of your accelerated Bruce protocols.
Yeah, but he's certainly got ST segment depression that we can see, which is quite marked. That's in V5, V6, V4. So I would think that looks a strongly positive, certainly by ST segment criteria. Not sure about symptoms, Peter, whether he got his operating room symptom at the time.
Did he get chest pain, Liz, on that stress test? You got tightness? A little bit of tightness in the chest. So what's the accuracy? I mean, is that all that we need to do, a stress test? I mean, can you tell us about, maybe Liz can chip in, she did the stress test, stress echo. What is the accuracy of stress testing based on that finding in comparison to a more sophisticated functional test, like a imaging functional test?
I mean, really, the predictive value of a stress test versus a stress echo is related to your risk factor profile. So, more risk factors, the more sensitive the test can be. But to be honest, a stress echo imaging, the ischemia will be first demonstrated in the myocardium before it's demonstrated in the ECG. So, stress echo will be a lot more sensitive in the patient with known coronary disease. So, in this case, I'll be very comfortable that that's a positive stress test. And I think in the context of him being a patient with a lowish risk factor profile, that's even more significant. And I think you've got to look so I always find with a patient with a positive CT calcium score or CT craniogram that a baseline stress test is probably just as important as doing one at any time, so you can follow and track that particular patient.
Thanks, Liz. Damien, I put that slide up, and I'm really sorry that this is not a longer session because these are really critical things. I put this slide up, Damien, because it was published by Tom Marwick, who happens to be on the steering committee for the MBS review. And the recommendation is that stress testing, treadmill stress testing, now become the gatekeeper for more downstream testing. In other words, you can't book a stress echo or a myocardial perfusion scan without doing an exercise treadmill stress test first. So it's curious, it's ironic that it's not signed off, but it's one of the recommendations of the MBS review process. And within that steering committee is Tom Marwick, and he's actually published a lot on this stuff. And I'm not sure if you can read the slide, Damien, but can you tell us a little bit about the downstream flow-on effects from just doing treadmill stress testing before you do a stress echo?
Well, we've all seen patients that have had exercise stress ECGs who ultimately have had a false negative rate. The sensitivity and specificity of stress testing is around about 70%, stress ECG that is. When we talk about stress echo, we increase that up to around about 85%. Okay, so we're going to pick up more patients that have got the disease. And my worry about exercise stress testing is that we're going to unfortunately give a large amount of reassurance or false reassurance to patients who ultimately have got a condition that needs management. And it's not just the fact that their stress test was normal, it's everything that goes along with the primary prevention of coronary disease. If patients have a normal stress test, they have this feeling in their mind that their heart's fine. If their heart's fine, then they can continue going to Dunkin' Donuts or McDonald's and having their high saturated fat diets and not following the Mediterranean diet like they should be doing. So, so as far as I'm concerned, when it comes to stress ECGs, I would be using that looking for arrhythmias, but I would never be using that looking to rule out ischemia, because I don't think it's a good enough test.
And the key thing about this slide is that it tends to lead to low quality, expensive downstream testing because of the lack of specificity, as was shown in that trial, compared to stress echo, which has high specificity and sensitivity.
But Peter, it doesn't matter as long as everyone goes on a statin.
Or a Mediterranean diet. And I find this stuff fascinating. I've actually changed my mindset to this, and I brought that issue about false positive stress echo intentionally because I'm now starting to think everything is kind of linked. I don't know that you can say that there is... We talk about specificity and sensitivity of stress echo, but what's it benchmarked against? It's benchmarked against coronary angiography, and we know coronary angiography is no good at predicting ischemia. So we're benchmarking a test against another test which can't predict ischemia. So these sensitivity specificity figures might actually be higher than that if you look at it in that context. So this is the stress echo. Now this absolutely makes no sense to me at all, but Liz Donnelly was concerned enough to give me an urgent phone call about... Liz, I think you said there was distal LAD territory ischemia based on the... and that's the other views. Would it be fair to say that that's the section that you were concerned? Yeah. So that's rest. The patient's at rest here, and this is exercising obviously because you can see the heart rate's quite fast. Sorry to, this is heretical to speak about stress echo from an interventional cardiologist, but that's the area there that Liz was concerned about. But that's the context of. So here, he's asymptomatic, or possibly we can convince him to be symptomatic. Modest dyslipidemia, clearly abnormal exercise treadmill stress test with provocation of chest tightness, and an induced regional wall motion abnormality in the LAD territory. He just came in for a screening test. Where to next, Alex?
Geez, that was a long drum roll, Peg. And geography, mate. Finally. Yeah, we'd have to.
So here's you tell, can you, sorry, I mean, normally you'd need to see all the images, but that's if you could just talk through this.
So just around that bend that you can see over on the screen to the left there, this is the right coronary artery, and he's got, it's moderate, probably maybe 40-50% stenosis. It's certainly not severe. Might warrant some hemodynamic testing, although there was no inferior ischemia, was there, Liz, on the stress echo? So likely to be okay, although that PDA does go out towards the apex. I think that says it all. I don't need to explain that. That's the LAD that we're looking at there, right in the middle, very critical stenosis. So medical management, Peter?
Mediterranean diet.
Orbiter. He looks like he's stent deficient in that segment.
So it's interesting. Alex and I entirely on the same page. I mean, the oculostenotic reflex kicks in now. Once you've gone down that path of investigation, it's, we call it the oculostenotic reflex in jest, but in fact, it's very hard not to treat a lesion like that. And in fact, if that patient was offered to be randomised in a trial or not, you'd have trouble randomising them in that trial. So the reflex is to treat that percutaneously. Does anyone have an opposing view to that would like to make a comment on it?
I think there's a fair chance that in the past that would have been treated medically, I would think. Asymptomatic. I didn't see the stress echo, but it's fairly limited distribution of ischemia. That looks a bit more apicolateral, Liz, was that right?
Yeah, exactly.
Yeah, and so questionable chest pain. He's not on medical therapy yet, which is the cornerstone of his longitudinal care, let's face it, right? And he's got a mid-LAD lesion, which is probably hemodynamically significant. I think in this era he gets stented, but in former eras he may well not have been stented, and may well have done perfectly well as we see in other clinical trials.
Can I just ask Jim, sorry to put you on the spot, Jim. I mean, Jim's got the most experience out of all of us here in intervention. He's seen it come and go, and he grew up in the balloon era. What's your bias towards these sort of patients, Jim, being mindful of the fact that, the initial presentation was for screening purposes?
He's got significant demonstrable ischemia, so I think he fits into a group that we think from balancing all the literature that he'd benefit from the stent. I think Malcolm's referring to, before we had stents, I looked at that lesion and I would worry about doing a balloon angioplasty on it. It looks like it's likely to dissect and you might end up with a higher risk of contributing conservatively. And the alternative is a coronary bypass graft surgery, which we wouldn't have good evidence. It's a mid-LAD lesion. It's not proximal, it's single vessel, he's got medullary function. So previously he would have been put in a better prognostic with medical therapy, but now we do have stents.
Yeah, you're right. Thanks, Mark.
You do have a way of treating him, and I think that all of our indicators, things like fame and other studies show that you'll get a better outcome with treating that.
So, look, the outcome is not the key to this discussion. It was more to introduce the dilemmas that we face and the challenges in dealing with these patients. I mean, at the end of the day, some of us are cardiologists, but at the end of the day, we're all medical practitioners. And I always think of it as a privilege when you get a patient sitting in front of you and they entrust you to guide them to the best approach for them. And I think we all try and do the best for our patients, and sometimes things are easy and sometimes not, and that's where the clinical judgment comes in, and that should never be underestimated. So he had a stent, and obviously, as Malcolm mentioned, medical therapy is really the key in the long run.